Check 1, 2, 1, 2.
Get right to it. Yeah. All right, it is 7:30 on the dot, and I think we should probably get started. Good morning, everybody. Thank you for coming to Department of Pediatrics Grand Rounds. It's my pleasure to introduce our speaker, Dr. Eric Bomberg. And I knew of his journey, but when I actually sat down to look at your CV, the thing that came to mind was Minnesota to California ping pong. So let me run you through his training. So he actually is a local. He grew up here in the state of Minnesota. He went to UC Berkeley to get his bachelor's degree in psychology, then came back to Minnesota to do some post-baccalaureate work, pre-med, went back to California, but this time to University of Southern California in LA, and got his MD. And then you came back and did a med peds residency here at the University of Minnesota. And then you went back to California, this time to UCSF, where he did a dual adult and pediatric endocrinology fellowship, and also got his master's in clinical research. Then he ping-ponged back, hopefully for the last time, to Minnesota. He joined our faculty just about a year ago. And so for being a junior faculty just getting started, he actually is pretty well accomplished. Already has 15 peer-reviewed publications, 10 presentations of abstracts at national conferences, wrote a book chapter, and he's currently working really hard on putting together a K-23 application that he's going to submit this fall that's going to be looking at precision obesity medicine, which is in line with the topic that he's going to cover this morning. But actually, probably your best accomplishment happened a few weeks ago, baby Zoe.
Yep.
So he's a brand new dad. So he's juggling all of these things. So anyway, we're really happy to have him on the faculty. This is a topic that's near and dear to my heart. So let's talk obesity. You're on.
Cool. Thank you. Anyway, thank you, everybody, and good morning. And so I wanted to, first off, obviously, my disclosures. I do receive some research support from both Novo Nordisk and Rhythm Pharmaceutical for a couple studies I'm working on. And I will definitely 100% be discussing off-label use of medications, because in our clinics, that's a lot of what we do. Another disclosure is I'm not actually a member of the Division of Pediatric Epidemiology, but I like to think that I am also. So the objectives of my talk today are to review prevalence, trends, and causes of pediatric obesity, to learn about the treatments for obesity, including lifestyle modifications, metabolic bariatric surgery, and pharmacotherapy, and to discuss considerations for individualizing choice, especially specific to obesity pharmacotherapy. So obviously this is like a ton of stuff, and there's going to be a lot of information coming and a lot of things available. And I think that my general kind of overall goal is to not like have everybody be an expert on how to do this stuff, but it's just to sort of give you a flavor about the sort of things that we do in clinic. And when we're thinking about putting, adolescents and youth on medications, some of the different thought processes that kind of go, basically go into our thought process about the sort of things that we're working and trying to do essentially, and the sort of things that we do in our clinic. So first, obviously, starting out with the review of the prevalence, trends, and causes of pediatric obesity. In order to start doing that, we really have to look at what it is exactly. So what defines pediatric obesity? So there's these categories known as overweight, obesity, and severe obesity. So overweight is a BMI. I'm just going to see if this works here. I don't know if I'm pressing the right button. Does that do anything with the slide? I was trying to... Oh, I guess not. Anyway, so overweight is considered to be a BMI of 85th percentile, but less than 95th, so 85th to 95th percentile. Obese is a BMI that's in the category of 95th percentile, and severe obese is in the category of 1.2 or 120% of the 95th percentile, or a BMI of greater than 35. So in EPIC, you'll notice that there is these growth charts that were created. These growth charts are actually out of the University of Colorado, and they're things that we use very routinely in our clinics. So you'll notice that on the very bottom there, you see like that's kind of the standard one that we're used to looking at, that 5 to 95th percentile, and then you notice that there's a bunch of other points above that. So 110, 120, 130, etc. Those are all percentages above the 95th percentile. And the definition of severe pediatric obesity is at that 1.2 line above that 95th percentile. So as far as prevalence is overall, it's about 19% of children and children and adolescents in the U.S. have obesity, and this severe pediatric obesity, that 1.2% or above category that we were talking about, is actually the fastest growing obesity category. There's somewhere around 5 million children or adolescents in the U.S. who have this, and these children are at greater risk for developing obesity-related complications and comorbidities, so the things that you would generally think about, type 2 diabetes, cardiovascular disease, etc. And unfortunately for these children, just lifestyle modifications, telling people, just go out there and diet and exercise, they are ineffective. In some studies have shown in upwards of 98% of the time for this specific population, just doing lifestyle modification alone is ineffective. So we have to think about other solutions or other things that we could potentially do. As far as the trends, obviously things overall are not going in a good direction. So there was a paper that was done about 8 years ago in the Lancet that showed that by 2030, 65 million additional cases of obesity in the U.S., 6 to 8 million additional cases of diabetes, 5 to 7 million additional cases of heart disease or stroke, another 500,000 cases of cancer, and obviously this is going to be associated with lots of costs in billions and billions and billions of dollars. So as far as the causes of obesity, as you are no doubt aware, obviously these things are truly multifactorial. This is a chart that I kind of adapted from another paper and put into another paper that I wrote before. And I kind of like to think about things in terms of what's known as risk regulators and internal factors. So internal factors are a lot of the things that we think about, things like the HPA axis, cortisol, the microbiome, the proteome, the transcriptome, the genetics, things like mood, depression, anxiety, etc. And then there's these risk regulators, which are other things that are out there kind of in the society. So things like cultural norms, right? The images of body images are now different than they were 30 years ago. There's a bunch of things with commercial messaging, parental influences for children. There's the local food environment, so the availability of healthy foods or availability of unhealthy foods that are around you. And then there's things like the built environment, which is, walkability, crime in your area, green spaces, etc. And a lot of the studies are showing that these things together, the arrow goes both ways. So it's probably these risk regulators are affecting these internal factors. These internal factors, to some extent, are affecting the risk regulators. And all of these together lead to, I have a lot of control on our health behaviors. So things like feeding behaviors, physical activity, etc. And all of this together can lead to increasing body weight over time. So that's just kind of a general overview saying basically, obviously, this is a very, complex thing, and it's not simple, essentially. So the next thing I wanted to talk about is learning about a little bit about the treatments for obesity, including lifestyle modification, metabolic bariatric surgery, and pharmacotherapy options. And then last, we'll kind of leave with discussing considerations for individualizing pharmacotherapy, which is going to be the largest chunk of, obviously, what we're going to talk about today. So the weight management visit. So when somebody comes to us, what are the sort of things that we should be thinking about or the sort of things that we should be doing? These are actually from guidelines that came out from the adult weight management guidelines that were in the Journal of Clinical Endocrinology and Metabolism in 2015, talking about pharmacotherapy for the treatment of obesity in adults. And they had recommended annual and symptom-based screening for conditions associated with obesity in all patients who have BMIs of greater than 30. And so this includes screening for things like type 2 diabetes, hypertension, lipids, obstructive sleep apnea, NAFLD, and depression. Another thing that we always want to think about whenever we see patients is identifying any other things that could be contributing. So there's things like sleep disorders, there's things like disordered eating, there's socioeconomic issues that we had talked about. There's a lot of, another very, very common thing, or another thing that I do for all of my patients is I look at the medicines that they're on and see if there's anything medicine-wise that's associated with weight gain, so we can kind of think about that a little bit more. And just as an example, here's a number of different medicines that people could be on, and this list is obviously non-exhaustive. So as far as diabetes medicines, insulin, sulfonylureas, and the TZDs are associated with some degrees of weight gain. Medicines that are used in psychiatry are a big one, especially the atypical antipsychotics. Things like SSRIs to some small degree are associated with maybe some weight gains. Lithiums and TCAs are also there's a lot of seizure medicines that are, including Tegretol, Neurontin, and valproic acid. Steroids are kind of a big obvious one that we think about, so things like prednisone, methylprednisolone, etc. And then there's others that are associated with at least some degree of weight gain as well, too. So things like antihistamines or beta blockers. So I always look at patients' medications list and I say, hey, look, are there anything big that we can work on or maybe eliminate or change doses of, etc. So another thing to always think about during our visits is screening for secondary causes of obesity, which is recommended to be done, quote unquote, as indicated, and it sort of depends on the situation. Some of these secondary causes include things like monogenic forms of obesity, so there's MC4R mutations, there's leptin deficiency, POMC deficiency. There's syndromic forms that are associated with obesity, so things like Prader-Willi or Alström disease. Neurologic conditions, so if somebody had brain injury, or if they had, these are the quote-unquote hypothalamic obesity, although to some degree I think pretty much all obesity is hypothalamic hypothalamic because the hypothalamus controls appetite and satiety. And then there's endocrinologic conditions as well, things like Cushing disease or hypothyroidism, growth hormone deficiency. And so kind of as indicated, depending on the case, we'll think about at least screening or checking for some of these secondary causes. But overall, these are like less than 5% of cases that we're going to see. And then finally, after we've looked at all of these things, we want to look at developing a treatment plan. And the big thing about the treatment plan is you want to do something that's intensive. You want to do something that's clearly age appropriate. You want to be culturally sensitive. And really, in the pediatric realm, it needs to be centered on the family, right? Something that people can do. So with that, obviously, the first thing that we need to talk about, because it's really the foundation for pretty much anything that we do, is lifestyle modification, right? Anything that we do, medications, surgeries, etc., this is really going to be the backbone of everything that we do. So as far as just kind of dietary principles, and all of these have evidence behind them, and so things that you at least want to think about, these all come out of the pediatric obesity guidelines that were in JCEM in 2017 by Dennis Nine and a bunch of other people. So you want to look at decreasing fast foods, added table sugar and high fructose corn syrup, decreasing high fat, high sodium or processed foods, reducing saturated dietary intake in children who are 2 years of age and older. You want to consume the whole fruit rather than the fruit juice, obviously. You want to try to eliminate sugar-sweetened beverages, which is a big one. I just had a patient that I saw yesterday in clinic who I had pointed out was drinking approximately 1 pound worth of sugar-sweetened beverages every week. So it's something that I always think about. You want to educate on portion control. You want to follow the US FDA intake of dietary fiber, fruits, and vegetables. There's timely regular meals is something that's also important. There's this concept known as grazing. I hate that word, but it's like, you know, eating a little here, a little here, a little here, versus trying to really consolidate things to the meals. You want to recognize eating cues. And so for a lot of our patients, things like, you know, they'll tell me they eat because there's really nothing else to do. Well, you know, maybe we should think about other things that we could do. Or stress, obviously, anxiety, depression, loneliness, just eating because you're in front of a TV. So we always recommend, if possible, to eat with the TV off, or actually in our situations, it's not so much the TV these days, it's the phone. So, or tablets or something along those lines. You want to encourage single portion package and improve food labeling. This last one, while the rest of these are evidence-based, the last one is not quite evidence-based yet. But these are just kind of general things to think about from dietary principles. That's what I said. Encourage, the last one. So, advertising. We kind of had briefly mentioned about it before, and I think it's always important to mention that this stuff can be very, very falsely misleading to a lot of our patients. And so this is ads that I had pulled specifically out of Tropicana from their website, talking about the benefits of juice and a glass full of nutrition. 2 servings of fruit, more than a day's worth of vitamin C, as much potassium as a medium banana. If you compare Tropicana with Coke, this is taking a look at 20 ounces of Tropicana versus 20 ounces of Coke. The Tropicana actually has more calories and about the same amount of sugar. So essentially, when we see these things that look at like, oh, this is 100% fruit juice, etc., you know, Tropicana, they always say it's 100% juice. It's really Coke with some vitamin C. And I think it can be very misleading for a lot of people. So exercise principles, obviously there's diet and exercise as the other background. Things that they recommend are 60 minutes a day of moderate to vigorous physical activity. There's this thing, I've never actually tried this before, but I saw somewhere in my reading this thing known as the talk test, which is, moderate activity is considered to be some activity that you can talk when you're doing it, but not sing when you're doing it. And then vigorous activity is that you can't talk or basically do anything without having to pause or catch a breath. So some of the things that actually one of the things that I pretty much do at every single one of my visits is I sort of provide a written prescription to engage in physical activity. So like we talk about, we kind of come up with plans about different things. At every single one of my visits, I always talk about food goals or something that you want to change about your diet. I talk about activity goals, and I do that to sort of do this written prescription to engage in physical activity. And then I always talk about medication and medication options as well. And so this may improve compliance, although I don't think the evidence is that great at this point. And the 60 minutes that they talk about do not have to be accomplished in one session. There was actually a really good study that was done out of the University of Colorado a number of years ago. They have a national weight control registry for adults. And in this national weight control registry, they collect people who have lost at least 30 pounds and kept it off over the course of the year. And they just do a bunch of studies out of this. It's just a huge registry. And so what they try to do is they try to say, hey, look, are there some factors that we can put together and say, there's something that's similar about these people, or what is it about these people? So for weight loss, one of the things that, has generally been found overall is that diet is very, very important for weight loss. However, one of the big findings to really come out of this group is that for weight maintenance, when you look at those people that are, that 10,000 plus people that are in the National Weight Control Registry who have lost 30 pounds and kept it off for over a year, it's really vigorous exercise that ties these people together. So most of these people in general do like 1 hour a day, every day of some form of physical activity. So it's really kind of stresses, the importance of exercise for weight maintenance. As far as screen time, obviously non-academic screen time, there's a number of different societies out there, U.S. Department of Health, AAP, and Endocrine Society. They all recommend around 2 hours a day or less. These days, whenever I ask the questions about screen time in my clinics, people actually seem to know the answer, because you can literally just pick up your iPhone and they're like, oh, I'm on my phone like 7 hours a day or something like that. And so like people actually now have a better idea, I think, or a lot of people that use their phones have a better idea. And I always think it's super, super important when you talk about screen time to not just talk about TV, because people just aren't watching TV as much these days because they're always on their phone or their iPad. So very briefly, I wasn't going to talk too much about this, and obviously this is not, this is just to kind of generally know that bariatric surgery is something that we do offer, is something that is available, and is something that is available in the youth population. There's a couple of different societies that are out there that give their recommendations on who are candidates to consider for bariatric surgery. One of those groups is ASMBS, which is the American Society of Metabolic and Bariatric Surgery. And the other group that gives their recommendations as well is the Endocrine Society. So you will see from these two sets of recommendations that the one from the Endocrine Society, because most of those people in there are not surgeons, are going to be a little bit more stringent. The ones from the Surgery Society are going to be a little bit less stringent. So as far as indications from the Surgery Society, so ASMBS, they recommend a BMI of 40 or greater. These are indications. So a BMI of 40 or greater, or 140th percentile of that 95th percentile, or you could do a BMI of 35, or the 120th percentile with any of the complications or comorbidities, which I'll show you in a second. They recommend that there be as an indication, you have to have a multidisciplinary team available. So you must consider whether the patient or the family have the ability and the motivation to adhere to the recommendations of treatments, both pre and post-operatively. So contraindications, if you have a medically correctable cause of obesity, obviously, if you have ongoing substance abuse problems within the preceding year, or if you have medical, psychiatric, or psychosocial or cognitive conditions that prevent adherence to any of the things that you have to do before or afterwards, or pregnancy, obviously. These are the ones from the Endocrine Society. You can see that they have in their guidelines a little bit more, which is not surprising because this group is more of, kind of medical side as opposed to the surgical side. And so they recommend the same sort of thing with the BMI categories. They also recommend Tanner stage 4 or 5, and having final or near final adult heights. As far as they also recommend that you have the extreme obesity and these comorbidities. They continue to persist despite compliance with a formal lifestyle modification program. They recommend a psychological evaluation that confirms stability and competency in the family unit. They want proof of ability to adhere to the principles of a healthy dietary and activity habits, and an experienced surgeon, and a plan to do long-term care afterwards. Their contraindications are relatively similar overall. Pregnancy, obviously. They say, look, if you have not mastered these principles of healthy living essentially before, that's considered to be a contraindication to doing surgery. And if you have these unresolved substance abuse, eating disorders, or untreated psychiatric disorders. As far as what these complications and comorbidities are, that would put you in a different BMI category when considering surgery. So basically BMIs of 40 versus 35. They are relatively similar, you can see, between the surgery group, ASMBS, and between Endocrine Society. And so type 2 diabetes, obstructive sleep apnea, if you had NASH, if you had the orthopedic stuff, so things like Skiffy or Blount's disease, pseudotumor hypertension, ASMBS actually puts GERD into that list as well too. And then there's things like dyslipidemia, etc. So now as far as okay, so we've kind of talked about lifestyle, diet, exercise stuff. We've talked recently about bariatric surgery and indications, contraindications for those procedures. And now we have this middle ground, which is medicines. That is a lot of what we do in our clinic, and a lot of what I wanted to focus, basically what I'm going to focus essentially the rest of the time on. So as far as FDA-approved anti-obesity pharmacotherapies in children, orlistat has been approved for adolescents between 12 and 16. Just orlistat. Really, it is just orlistat, and orlistat doesn't really work that well. So I don't think I've ever prescribed orlistat for an adolescent patient in my life. I prescribed it a couple of times in adults. So in adolescents, they do say in adolescents greater than 16 years, and we've, in our group had discussions about what greater than 16 years means. So does greater than 16 years mean 16 years in one day? Or does it mean 17 years? And so I think that's kind of a little bit debate. But in general, you can think of either people who are about 17 years old and have a BMI of greater than 30 or a BMI of greater than 27, plus some of these complications or comorbidities. They say you can consider adult medications. This is a line from those practice guidelines that were put out in 2017 from JCEM, where they specifically state that physicians should be discouraged from prescribing weight loss medications and off-label to those who are less than 16 because there is no FDA approval, there is a limited number of well-controlled trials, there is limited efficacy demonstrated in adults for a lot of these agents, and there is the need to weigh the relative risk of drug-induced adverse events in children. And so they say because of this, we recommend for people who are less than 16 years or less that you do not use obesity pharmacotherapy. This is recommended from JCEM. However, at the same time, at the end of last year, there was this paper that came out in New England Journal that I thought was actually a very good paper. And basically what this paper essentially shows you is that you could see this is percent of obesity. This is followed between the age of 0 and 14 years old. This was a longitudinal study where they tracked kids over a portion of time, and that I guess orange category there at the top was people who were in the obese category. And generally what this is showing is this is showing that if you are obese by the age of 4, so 0-4 over there, bring it up to 75%. So if you are obese by the age, or if you have obesity by the age of 4, if you suffer from that disease by the age of 4, you have a 75% chance of suffering from obesity when you are 14 years old. So a very, very good chance, and 75%. And furthermore, if you have obesity as an adolescent, your chances of having obesity as adults are pretty close to 100%. So in other words, like by the age of 4, right, we got to think about doing things at younger ages and earlier intervention. Also part of this study, they really looked at when was the time that had the largest weight gain in those who eventually went on to suffer from obesity, and that really happened between the ages of 2 and 6. So the greatest weight gain was coming on between the ages of 2 and 6, and if you have obesity by the time that you are 4 years old, your chances of having obesity by the time that you're 14-year-old or an adolescent is about 75%. This all signifies the need for earlier interventions and thinking about earlier interventions. So with that, I wanted to go on about discussing considerations for individualizing pharmacotherapy. So from the FDA, these are the agents that are currently available. There are 5 of them. Orlistat, lorcaserin, Phentermine, Topiramate, which is also known as Qsymia, Naltrexone, bupropion, which is also known as Contrave, and liraglutide, and there's a 3 milligram dose that is known as Saxenda. So these are the agents that have been approved. They were all approved, I would say, relatively recently, aside from Orlistat. The one I did not put up there is Phentermine is approved for short-term use, just by itself. That one was actually approved back in 1959. So aside from that, Orlistat came in around the year 2000. The rest of these came in really earlier 2010s, like 2012, 2014. They haven't been around for that long. As far as the amount of weight loss that you can get, this is looking at the percentages of weight loss from these agents, and you'll see that in general, they're somewhere in the ballpark of 5 to 10%. And at least from the studies, the one that seems to have the biggest bang for your buck, but I think it depends on the individual patient, and when we talk about individualizing treatment, you'll see that in a moment. The one for, at least from the studies, that seems to have the biggest bang from their buck is this Phentermine Topiramate, so around 10% of weight loss after a year. Now, those are the 5 that were quote-unquote FDA approved, but what about other options and other things that are available? So these are other medicines that we use in our clinics, that we think about using in our clinics. Orlistat, Phentermine, Topiramate, this is the Qsymia one. Exenatide is another Glp-1 agonist, which is in the same category as liraglutide. Metformin has its purposes. Naltrexone by itself, as opposed to just the naltrexone bupropion, which is the one I showed you, lorcaserin, and lisdexamfetamine, which is also known as Vyvanse, and other stimulant medicines. So when we're thinking about how to individualize therapy and which options that we may want to consider, I think we really have to think about it in terms of these 6 things, right? These are the things that really help us to decide which medicines we are going to consider for each individual person. So if we were to, treat everyone, one of the things that I say that's really important is that we really need to treat everybody according to what the cause is. Right? And so, for example, I have patients that come to me in clinic and they have severe depression, right? And they're so depressed that it is causing them to eat all the time. Well, if we didn't address that depression issue, for instance, why do we think that things would get better if we were to just put them on an appetite suppressant medicine, right? If that's not their problem. Or we have some people who have very high hunger and maybe, let's say that we thought that we'll just treat you because you have anxiety or something, and we treated the anxiety, we didn't treat the high hunger. Why would we think things got better? And so this is where I think things get down to individualizing therapy. So these are the 6 different things that I think about when I am thinking about individualizing my medication therapy in clinic. First is mechanism of action. So what does it do? So these are the 5 that we talked about, and obviously the mechanism of action for a lot of those other ones is kind of similar depending on what the class is. So you have Orlistat, you have lorcaserin, which is a serotonin 2C agonist. You have Phentermine Topiramate, which is, Phentermine is a stimulant medicine. Topiramate is a medicine to this day. We still don't exactly know how it works to cause weight loss, but we have known since the 1990s, late 1990s, that it does. We believe that it has to do with the modulation of GABA pathways, and so glutamate and GABA is some modulation in there that leads to things like appetite suppression. And satiety, or basically improving satiety, and maybe helping with some binge eating tendencies as well too. As far as naltrexone, bupropion, naltrexone is an opiate blocker, and bupropion is an antidepressant or an SNRI medicine, and liraglutide is a GLP-1 receptor agonist. As far as then, so that's the first thing I think about. What is the mechanism of action? Because that may help me think about, what is the potential thing I would think about choosing, why would I consider choosing this agent over another agent? As far as side effect profiles and contraindications, these are other things that we at least want to think about. So this is very briefly for orlistat. Side effects include GI upset, fat-soluble vitamins, because it basically causes you to malabsorb food, so you got to think about your vitamins. Contraindications obviously include if you already had malabsorption issues, this will worsen it. If you have gallbladder disease is also a contraindication. As far as phentermine is a stimulant medicine. This also applies to anything else that we use that are stimulant medicines, Vyvanse, etc. Is that any stimulant medicines are obviously going to increase things. So cardiac, restless, insomnia. There is at least some concern out there, but it really hasn't been reported in studies about the potential abuse dependence issue. In studies, that hasn't really been shown to be the case. Contraindication, so obviously you don't want to put somebody on a stimulant medication if they have a history of cardiovascular disease. If they have hyperthyroidism that's already stimulating things and that's uncontrolled, obviously. If they had uncontrolled hypertension, I think if somebody has some degree of hypertension and they're on a blood pressure medicine or even two, I'm actually okay with using phentermine, and I do that all the time in my adult patients. If they have glaucoma, if they have agitated states, things that would increase things, right, are considered to be contraindications to phentermine. As far as topiramate, the major side effect, topiramate is actually a pretty well-tolerated medicine. We tend to use smaller doses than the ones that are used to treat. So this medicine was developed for the treatment of seizures and prevention of migraine headaches in adults. And we tend to use smaller doses, and so it tends to be relatively well-tolerated. The major side effects that we see are some patients have some intermittent paresthesia issues. The one that we definitely look out for is there's been described at least things like cognitive and memory impairment, and these things I think have been shown, and so it's something that we're definitely cognizant about. And definitely topiramate is associated with cleft lip, so it's a teratogen. And not only that, but it actually decreases the efficacy of the birth control pill if you're on a birth control pill. So it's kind of a double whammy in that thing. So you want to think about that. The contraindications are glaucoma and a history of calcium oxalate renal stones, which are relatively rare types of stones. There's very few times that I end up coming up with a contraindication for the use of this medicine. If you had really bad kidneys, that would be another one to think about too. Lorcaserin this medicine can lead to things like headaches, dizziness, fatigue, dry mouth, constipation. Contraindications to this would be use of MIOIs. And you want to have caution in patients who are on SSRIs because the combination of those two could theoretically lead to serotonin syndrome. As far as naltrexone, things like side effects include elevated liver enzymes and GI distress, and contraindications for this because it's an opiate blocker. So if you are currently on opiates and you need opiates for something, this medicine is going to make you very unhappy. As far as Wellbutrin, the other component of it as well. So Wellbutrin has actually been shown to increase heart rate, agitation, dry mouth, headache, and GI distress as well too. And contraindications for bupropion include seizure disorder, eating disorder, MAOI use. And so these are non-exhaustive lists as well too. And so the reason why I bring these up further, finally, GLP-1 agonists. So these ones can lead to GI upset. They can also increase your headache. Theoretically, if you had diabetes, they can cause hypoglycemia. Pancreatitis is the big one that people hear about. But actually, cholecystitis is probably a bigger problem than pancreatitis with the GLP-1s. So if you had a history of pancreatitis, or you always hear about your history of MTC or MEN2, medullary thyroid cancer, multiple endocrinology, neoplasia type 2, those would be contraindications. And finally, metformin can cause GI upset. And if you had a history of lactic acidosis, although that's never been reported in pediatric trials. The reason why I think about what these side effects are and contraindications are contraindications are obvious, right? I mean, if a patient has a contraindication, you're not going to prescribe the medicine for them. But you want to also think about the side effects, because if they have other things that are going on in their life that could make, like if they already have a lot of GI upset issues for other reason, chronic abdominal pain, etc., you might want to think about maybe a GLP-1 agonist might not be the right choice. So that's like an example, for instance. So you want to think about the side effects because theoretically you could worsen them if they're already going on in a patient. Another thing, and this is one of the really big important things that I think about, is the eating phenotype of the patient. So really, what drives us to want to eat? Because these are different in different people. So there was these proposed eating phenotypes that are out there, and we kind of want to think about these, and all of these are, meant to, or all of these can contribute to obesity in some standpoints. And you really want to think about tailoring your treatment based upon what the eating phenotype is. So for example, if you had poor satiety issues, if you had a tough time getting full, or if you had strong hunger issues as well too, one of the things that you may want to think about is this concept known as volumetrics-based eating. Volumetrics-based eating is the concept of focusing on foods that cause you to feel fuller for longer, because they're tricking your brain, essentially. And so instead of like, I used to eat cereal in the morning, and whenever I would eat cereal in the morning, have a bowl of cereal, quick carbohydrates, and guess what? I'm hungry 2 hours later. Now instead, I do something like having eggs in the morning, or egg whites in the morning, because after that, those things are full of protein, I have a little egg whites, and now I'm not hungry again until 2 p.m., because what that's doing is that's tricking my brain into thinking that I'm fuller for longer. And so, foods that do that are things that are higher in protein, things that are definitely the concept known as wet volumetrics, which are foods that are higher in water content and fiber content. So things like spinaches and things like cucumbers and watermelons. And so there's a number of these different foods. And so if you have a tough time getting full, or if you have very strong hunger, I think focusing on these volumetric-based feeding, or, eating, essentially, is a very good strategy. Now, if you had strong hunger as well, another thing you may want to consider is you may want to consider using an appetite suppressant. As far as emotional eating, we talked about that before. If depression or anxiety are contributing to your eating, you want to look at treating the depression or anxiety. As far as night eating, so we have a number of patients who come in and they'll wake up at 2 or 3 o'clock in the morning. You really want to focus on strategies that are related to sleep and good sleep hygiene and making sure that that stuff is not happening. Binge eating, there's actually a binge eating disorder, which has a set of diagnostic criteria out of the DSM-5. And then there is binge eating tendencies, which means that you don't necessarily fit all of the DSM-5 criteria, but you fit some of them. There are actually medicines that are approved in adults for the treatment of binge eating disorder. And the major one that has been approved is Vyvanse or lisdexamfetamine. And so we do use these medicines in patients that we identify as having binge eating tendencies or binge eating disorder in children as well too. But sometimes the insurance can be a little bit more tricky with that one because it's expensive. But I've been able to get it through. So Vyvanse is one that has been approved. Impulsive eating, obviously you want to look at treating anything impulsivity related. And hedonic eating, which is really, I really like food or eating for reward, you want to determine alternate reward options. So I think it's really important to consider the different phenotypes and what's going on when you're deciding upon the treatment option and when you're deciding upon what medication you may want to choose for people. Finally, next, I think about things like patient comorbidities, and so there's a whole list of things. So the thought with patient comorbidities is really you can kind of get added when you're choosing your medication option. If you can get a double whammy for your medicine, you may want to consider that. And so for type 2 diabetes, for instance, that's a classic one that we think about. The GLP-1 agonists that we had talked about, liraglutide, all those other medicines, those are very good options because they both lower your A1C, and they can help with weight loss as well too. And very, very recently, liraglutide just became the now second medicine not named insulin approved for the treatment of type 2 diabetes in children. So beforehand, the only two options that we had that were actually approved, we would use other things, but the only two approved options were insulin and metformin for like years and years and years, up until just recently, liraglutide got that approval as well too, which I think is going to be a game changer in this in this, for this disease, I think. If you have diabetes and hypertension, you may want to consider using medications like ACEs or ARBs or calcium channel blockers before beta blockers, because those are associated with some weight gain. If you have depression or psychiatric issues, you really want to, shared decision making obviously is an important thing in thinking about treating those things. But another medicine that may help is technically bupropion is an SNRI medicine, so that may be one that you want to consider there. If you really want to, if you're somebody who smokes or uses alcohol and you really want to quit, well, naltrexone is an opiate blocker, so that may help with that as well too. If you, for people who want contraceptions, OCPs are actually associated with smaller degrees of weight loss than injectable contraceptives. Atypical antipsychotics, there's a number of different studies, and I think it's pretty common these days that for people who are prescribed atypicals, things like Abilify or Seroquel, etc. Metformin. There's a number of different studies that metformin can actually reduce the weight gaining properties that are associated with the atypical antipsychotics. And so if I have a patient who is on one of those, I will almost always, or a very, very good portion of the time, use metformin in those patients. There's actually a couple of studies out there that actually show that Topiramate does the same thing, and there's actually also some studies out there that show Glp-1 agonists do the same thing too. So for patients that are on atypical antipsychotics. And then there's this orlistat. We're not going to talk about that because I don't really use it. Another thing that you want to think about is cost access issues with these medicines. There was, so many insurance companies require prior authorization for pharmacotherapies, and they will not approve off-label use of medicines. And so this is something that we commonly run into. So we really have to think about cost issues and kind of how we get around them, because some of these medicines are very expensive. At least coverage is getting a little bit better, is what this is meant to show you. And I've even had cases where you need prior authorization to even be seen in a weight management clinic. So in order to defray costs, there's other things that we could consider, like you could consider adding alternative diagnoses to the visit itself, so not just coding the visit as being obesity, but hypertriglyceridemia, or coding diabetes or hypertension or other things. There's manufacturer websites and coupons that are out there. If you actually shop around to your pharmacy, you can find different options of things that are available, because there's actually different costs at different pharmacies for some of these medicines. So one of the things that we'll do is if it's a pill that can be split, we can split it. Probably the biggest thing that we do is, if you look at that one that we talked about before, that Phentermine Topiramate combination, we can prescribe those two separately. Now, this is not FDA approved to prescribe them separately, but these two together, if you had to pay out of pocket, would be like $25 a month, or something, maybe $30 a month, or something a lot cheaper than the $300 a month it would be to prescribe that Qsymia, which is the combination of those two. And I have most of my patients, pretty much all my patients, know about GoodRx, which is something that is available to do some medication shopping. You can print out a coupon and stuff like that. So finally, you want to think about patient and family preference issues. And so really there's an importance of discussing the benefits and risks every single time you're going to use a medicine. You definitely want to discuss the fact that, look, these options that we're choosing, especially in pediatrics where basically nothing is approved, all of the stuff that we're doing is not FDA approved. And so I think it's really important that you let your patients know that you document that what you're doing is not FDA approved, because, that's important for ourselves, I guess. And so you really need to have discussions about the benefits, the risks. And another thing is that we don't generally think about, oftentimes I think too is, especially in the pediatric side, there's things like, well, what are the super long-term risks of things that we're doing? If we put somebody on a stimulant now, is this going to lead to increases risk of osteoporosis when you're 60? Or, there's a number of different things, because now we're really looking at a very, very long time frame, which is something that was different when we were thinking about things in terms of adults. And in truth, as you could see, a lot of these medicines didn't really roll around until the 2010s. And so we don't really know that much, I think, in terms of super long-term things. And so I think it's important that people that you're going to be prescribing these medicines know these things. And share decision-making. I always tell people that my job is really to not tell people what to do or what not to do. My job is to provide information. And what we do together is we think about things, you know what's up, I know what's up, we can think about things together and we can try to come up with a plan. So finally, there is this role for precision medicine. Precision medicine, new hotshot area. There was the Obama administration put out something talking about we need to increase precision medicine efforts. And so what is precision medicine? It is considered to be an emerging approach for disease treatment and prevention that takes into account individual variability in genes, environment, and lifestyle. This is an expanded definition from the older definition that we had, which was all about precision medicine as just genetics, and saying, hey, we're going to tailor a medicine to somebody's genetics or somebody's genes, right? That was the older definition, and then people realized it's not necessarily just genetics, right? There's a bunch of other things, environment, lifestyle, all these other things. It's just the concept of tailoring a medicine for an individual person. This is the definition out of the NIH. The goal really here is if you're able to tailor that medicine for that individual person, you can increase your benefit and you can minimize your risk. Because you're basing things either based upon psychological factors or things based upon somebody's phenotype or somebody's genotype. And there's a lot of different techniques that can help in precision medicine. So things like you looking at people's phenotypes and trying to figure out if there's certain phenotypes that would respond better to some medicines than others. We can use things like electronic health records to do this sort of thing, or large-scale observational studies, other things like that. There are pharmacogenomics, which are studies that look at the interaction between the genes and the drug response. There's pharmacometrics, which is looking at an individual's relationship between how they metabolize medicines, how medicines move their way through their body, and how they respond. There are biomarkers that can predict. There's use of things like functional imaging, like looking at MRIs and functional MRIs and stuff like that, and how that can predict. So there's a number of different techniques that are out there. So examples of studies that are out there that have kind of looked at this precision medicine approach for the treatment of the disease of obesity is that there was a study that showed that carriers versus non-carriers of this TSA haplotype in this INSR gene had greater weight loss to Topiramate. That's just an example of one study that was done. There was another study that looked at functional MRI that showed that baseline activation of the amygdala, the parietal, certain regions of the brain was correlated with weight loss response to lorcaserin. We actually did something, we looked at exenatide and we looked at patient phenotypes for exenatide here back in, what was it? 2014 or 15, I can't remember, that showed that females had, I wrote it down there, 2016. So females had greater weight loss to exenatide compared to males, and maybe that has something to do with different leptin concentrations. And then there's a bunch of things that are out there looking now at polygenic risk scores, and the concept behind a polygenic risk score is that each individual little gene can contribute a small amount to something. So what if you add up a bunch of genes together, you can try to contribute to more of the, you can try to find something that contributes to more of the variability. And so there's a number of different studies that are out there showing that polygenic risk scores predict greater weight loss response to different lifestyle modifications, bariatric surgeries, and what I'm going to be looking at in my proposals right now are medications as well. And really this field, I think, is in its infancy. So to summarize, pediatric severe obesity is a very fast-growing category of obesity. It's the fastest-growing category of obesity. The causes are clearly multifactorial, and you really have to look at what that individual cause is in that individual patient when you're considering choices for individualized treatment plans. Lifestyle modifications, we talked about a fair amount. That's really the background for all treatment options. And when you're individualizing your pharmacotherapy options, you should consider the mechanism of action, the side effect profiles, clearly contraindications, eating phenotypes, the different things that are causing people to want to eat, patient comorbidities, because you can sometimes get a double whammy, cost access issues, and patient and family preference, obviously. And there definitely is a role for precision medicine, and there's a lot of future directions going on. So, questions? What? I think we're...
Thank you, Eric. Really nice talk, and it's nice to see things moving along here. For most pediatricians, I'm sure that stepping into the area of prescribing these drugs is something that's probably not going to be part of everyday practice, at least not right now. What's the fail point in general pediatrics? You've said, if you're obese at 4 years old, you have a high 75% likelihood of obesity at 14. What's the fail point, if you think, for a standard lifestyle modification, and when do they need to be moved out of a pediatric practice to a weight management clinic?
That is an excellent question, and I think that is something that we don't necessarily have a great answer to, and I think that that's something that we need to try to come up with better responses to that. But I think that the major thing that we need to be thinking about in kind of the general pediatric approaches is really looking at things that are younger. I think that that's the important thing that's going on, is that really what often ends up happening is I remember, at least back when I was doing my pediatric, my pediatric training, and when I was, just in my continuity clinics and stuff like that, and I was seeing, the 2-year-old patients and the 3-year-old patients and stuff like that. And this is just my own personal experience, right? I wasn't really thinking about the fact that somebody at that point had obesity at that point. It was like one of those things, and I was like, but they're really young, they'll grow out of this thing, these were the thought processes that were going through my mind. And now that I kind of really dig into this thing and get in there, I realize that, 75% of the chance they probably will not. And so we really need to be thinking about sending people along, considering things like medicines, considering alternative strategies and things like that earlier. We actually do prescribe some medicines down to fairly younger ages. I know that Dr. Fox, Claudia Fox, has a couple of patients on Topiramate down to the age of 2. In her clinic. I think the youngest I have in my clinic is 3 years old. Really, when we're kind of thinking about in terms of that younger age, 2, 3, 4, 5, that's where we take very aggressive approaches in our clinics. And so we have monthly follow-ups for these patients. We definitely put a lot more onus on looking at things like genetics and referral to genetics. Looking at, other things that are, psychosocial or other things that are going on. But I think it's a very challenging question, but I think that we should really be thinking about this earlier than we have been thinking about this. But what is the tipping point? I don't think we really know that answer.
Here, come back here with the microphone. Yeah. There was a pretty widely published article a few years ago kind of looking at the Biggest Loser kind of contestants and how they not only did almost all of them gain back weight except for like the one who had bariatric surgery afterward, but like their metabolisms never recovered, that they kind of stayed in this starvation state, and so it's kind of you're fighting a losing battle. Yep. And so like how you, like when you have successes with these kids, how you kind of overcome that, how like is there anything they can do to kind of help boost their metabolism? Is there like a microbiome kind of thing, anything that can kind of help with that sort of?
That's also another good, very good question as well. One, I think part of that has to actually do with the, personally, I think that part of that has to do with the education that we provide around that this is going to happen. I will give you an example. One of the things that commonly comes to me is people say, look, they'll come to me, they'll start just exercising a ton. Right? And what they'll say is, hey, look, I'm burning off all this weight. I wasn't doing anything before. I wasn't exercising at all. And now I'm going out there and I'm running 10 miles a day. Oh, I should be able to eat whatever I want to now. Look at this. I've burned off all this weight. I can do this stuff. Well, so what actually determines, our caloric needs, right? A biggest portion of our caloric needs are really determined by our resting metabolic rate. So basically, how many calories are we burning off when we literally sit there and do nothing? That's the part, and then there's the energy, there's the caloric stuff from energy, but there's really the resting metabolic rate. The resting metabolic rate depends upon somebody's weight. That's how we calculate it. And so what happens is that your resting metabolic rate, as you lose weight, your weight is going to go down, so therefore your resting metabolic rate is going to go down. And so I think it's a big misconception that we see is that a lot of people will go in and say, hey, I'm super active, I'm burning off all this weight, I can eat more. But really what ends up happening is really you actually require fewer calories at that time. And so I think educating people to the fact that, this does not necessarily mean that you can now increase dietary intake is important. And there probably is going to be things in the microbiome that I'm not entirely sure about, admittedly, but I think that there are going to be other things as well, too.
The concordance with parental obesity high?
Yes.
Pediatric obesity?
Definitely. I don't know the statistic off the top of my head, but very high. And so that's also another thing that's really important, and one of our major barriers in clinic as well, too, is that this needs parental buy-in, right? I mean, anything that we do, whether it's a medicine, lifestyle intervention, et cetera. And unfortunately, one of the sad things that we've seen is we've tried to institute a couple of these family-based clinics where we say, look, we will treat everybody together. And I do have a few families that I have one family that I treat, the daughter, the mother, and the grandmother, like 7-year-old grandmother, all in separate clinics. But I think that sort of picture is really rare. And unfortunately, I know that we've, had some pushes to do more family-based clinics, and attendance to those has been really low, but I think it really, really stresses to the importance of really this needs to be a family buy-in.
I just had a follow-up thought to the first question was maybe when in doubt and you're thinking about referring to weight management, just go ahead and refer. It doesn't mean that you necessarily are committing a child to medication. Yes. So just go ahead and refer. You're not committing them to necessary follow-up if they don't need it. And the dietitians at the weight management are really excellent at finding very individualized, tailored dietary plans and meeting families where they are and making small, realistic, healthy improvements to diet. So
yeah, and I would fully agree with that too. If there's any question or adult, I think it's fine to send over to us because there's, our job once again, I think, is to provide information and to let people know that there are different options available. And because I think a lot of people will get discouraged where they say, oh, I've just been doing diet exercise forever, and right, they don't think about the fact that theoretically, things like medicines or surgeries or really individualized plans or things like that are available. And it's our job to come in and provide this information. Cool. Well, thank you, guys. I realized I started to realize part of the way through, and I didn't realize.
You have been disconnected from the meeting.